Hello guys, this is Dr. Asif. Today I'm going to continue the pathology sections of MRCS, which is MRCS study with me. So it is the middle of the pathology because I have divided the pathology lectures into three different parts, that is part 1, part 2 and 3. So let's begin the part 2 session. So now it is the part of pathological portions that is usually in the hematology, I say. So the disseminated intravascular coagulation, it's very important in case because it's a surgical emergency and also the gynecological emergency. So simultaneous coagulations and hemorrhage caused by initially formation of thrombi that consume clotting factors. So after the extensive surgery or after any bone fracture or hip bone injury or pelvic injury, there is a increased chances of hemorrhage followed by thrombosis, and after the thrombosis that thrombi may dislodge and forms different kind of obstruction in the vessels. It's also called the coagulopathy. Okay, so why disseminated intravascular coagulation, that is DIC, happen? Due to the deficiency of factor 5 and 8 platelet, ultimately leading to bleeding. So bleeding is the consequence of the DIC. So here what are the causes? Maybe so infection, there is severe infection like cellulitis or like thrombophlebitis or arteritis, vasculitis. So these are the infections and malignancies, that is long bone malignancy like osteosarcoma or multiple myeloma, also lymphoma. So it may causes coagulopathy nature. Then trauma, that is major surgery, burn, shock and dissecting aortic aneurysm. Though dissecting aortic aneurysm is very much prone to Marfan syndrome, patient with Marfan syndrome, so Marfanoid disease. So it is dissection of aortic aneurysm is not more common in our continent, but it's so common in Western world, because there is dissecting aortic aneurysm happens or rupture aneurysm happens due to overuse of alcoholism. Then there may be a lung disease and obstructive complications, which is more common in our country, and women are dying every day due to the fate of DIC. What are the key points? That is clinically bleeding is the main features, dominant features, bruising, ischemia and the organ failure. Okay, so there may be bruising, ischemia, organ failure. So how can you know or notice that these patient might have the DIC? That is organ failure, clinically bleeding, and blood test, that is prolonged clotting time, thrombocytopenia and decreased fibrinogen and increased fibrinogen degradation product, and treat the underlying cause of supportive management. Okay, so there may be a prolonged clotting factors and more less bleeding factor. So that is, we know that there is a deficiency of platelets, so in that case thrombocytopenia occurs, and increased fibrinogen degradation. So fibrinogen is the elements or clotting factor, which is also called the essential clotting factor, that is number 1 intrinsic factor. Okay, so here the D dimer, I think it's one of the important factors, that is D dimer. The investigation D dimer is not absolute, but relatively it can took this kind of things. By increasing D dimer, there is a chance of DIC. So disseminated is a mnemonic immune complex, then snake bite, shock and heat stroke, SLE since systemic lupus erythematosus, then eclampsia and HELLP syndrome. It's a very emergency condition in obstetrics, where the eclampsia, that means convulsion along with increased blood pressure in the intrauterine period, that HELLP syndrome occurs. Okay, hemolysis, eclampsia, and low platelet count. So massive tissue injury. So if in case of extensive surgery or long bone fracture may causes massive tissue hemorrhage, infection viral or bacterial, neoplasms, and acute myeloid leukemia. I already told you in the case of malignancy, there is lymphoma, leukemia, these are involved. Okay, and the tissue factor and like factors released by carcinoma of the pancreas, prostate, lung, colon, and stomach. Okay, endotoxin, bacterial chemical signal, that is toxin liberation, which can also forms coagulopathy. So it's a condition like endotoxin from gram-negative bacteria might cause coagulopathy and followed by DIC. In case of dead fetus, if retained. So how can you diagnose a disease of DIC? Because in case of DIC, coagulation, fibrinolysis are coupled, because these two things occurred simultaneously and combinedly. The activation of coagulation cascade yield the thrombin that converts fibrinogen to fibrin. This is the very important things. The coagulation cascade must be activated. Thrombin that converts fibrinogen to fibrin. So that means coagulation cascade may form thrombi, and that may convert fibrinogen to fibrin. The stable fibrin clot being the final product of hemostasis. So fibrin must be stable, okay, forming hemostasis. The fibrinolytic system breaks down fibrinogen to fibrin. The activation of fibrinolytic system generates plasmin. In the presence of thrombin, which is responsible for lysis of the clot. The breakdown of fibrinogen and fibrin results polypeptides. No need that. So in DIC, processes of coagulation fibrinolysis are dysregulated, and the results is widespread clotting and resultant of bleeding. So you all can see that coagulation and fibrinolysis, these two things must occur step by step. If that is dysregulated or can cause it simultaneously, in that case coagulation system is hampered and the bleeding is prolonged. So one critical mediators of DIC is the release of transmembrane glycoprotein, and transmembrane glycoprotein is the present on the surface of the cell type, that is endothelial cells, macrophages, and the monocytes. It is not normally in contact with the general circulations. That means it is not usually found, but in case of DIC, it may be found in the blood circulations. Particularly interleukin 1. For example, transmembrane protein is released in response to exposure of cytokines, which is interleukin 1. It is a risk factor or triggering factor for DIC. Another one is tumor necrosis factor, that is TNF endotoxin. This plays a major role in development of DIC in the septic condition, and the transmembrane glycoprotein also abundant in the tissue, that is lung, brain, and placenta. So in these three organs, transmembrane protein is usually found more. This helps to explain why DIC is readily developed in the patients with extensive trauma. So now the factor 7, which significantly triggers intrinsic factor, that is 12, 11, and 9 of coagulations. So it may also hampers that. So DIC readily developed patient with extensive trauma, that I already said that, and activation of transmembrane glycoprotein, and bind with the coagulation factors that triggers extrinsic pathway, that is factor 7, and subsequently also trigger the intrinsic pathway, the factor 12, factor 11, and also factor 9. You need to memorize this chart. It's very important, because in case of exam, sometimes the examiner may ask like this: the patient is taking rivaroxaban or apixaban for 6 days. In that case, we are going to perform an operations. In how many days before we need to close or stop rivaroxaban or apixaban. So for that you know, we must know that in which mechanism rivaroxaban or apixaban works. So and these are the reversible process. So exact time date is very important because you have to stop the drugs to prevent extensive bleeding during operation. So you must memorize this chart is very clearly, because in the exam sometimes SBI is asked from this chart. Now cardiac marker, these are the causes you have already discussed in your third year, that is the cause of different abnormal heart sound, because injection systolic aortic stenosis, pulmonary stenosis, and ASD phallus-tetralogy. And in case of pansystole, that is mitral regurgitation, tricuspid regurgitation, and VSD. Okay. And late systole in mitral valve prolapse, coarctation of aorta. And early diastolic aortic regurgitation, Graham-Steele murmur or pistol shoot murmur in the pulmonary regurgitations, the mid diastolic mitral stenosis. Okay. And severe aortic regurgitation. So these are the heart sounds, abnormal heart sound may cause due to that diseases. Okay. Now the nerve injuries. So there are three kinds of nerve injuries, that is neuropraxia, exotemesis, and neurotemesis. So what it is actually, what are the difference in between three? Nerve intact but electrical conduction is affected. Remember this very clearly. There is no nerve dissections, but only electronic subsupply is also affected. Full recovery. So this patient might go through disease process, but it will be cured. Automatic functions preserved. So there is autonomic function, that is sympathetic parasympathetic system is not affected in neuropraxia. In valerian degeneration does not occur. So because valerian degeneration means the axonic trauma followed by repairing of the process. So but in case of neuropraxia, there is no need for valerian degeneration. It will give full recovery after a few days later. The exotemesis, axon is damaged and the myelin sheath is preserved. This connective tissue framework is not affected while degeneration occurs. Okay. So it is also the axon is damaged but the wall is intact. In that case, it also been treated conservatively. Then the neurotemesis, disruption of the axon, myelin sheath, and surrounding connective tissue. Okay. So neurotemesis, disruption of axon and myelin sheath, surrounding connective tissue. It is very extensive, very bad, and very devastating complications of neurotemesis, because the patient might have upper motor or lower motor neuron lesion, and there is no control in bowel and bladder habit, and also sexual functions as well. Now the valerian degenerations, axon degeneration distal to site of injury, typically begin 24 to 36 hours of injury. Axons are excitable prior to degeneration occurs. Okay, because they are made of nervous system. So when you will give some stimulus for resection or doing something great, the nerve will respond, and it will prior to degeneration, it also can be happening, this kind of concussion at least. Then myelin sheath degenerates is phagocytosed by the tissue macrophages, and so after that, after the valerian degeneration process, the myelin sheath that is previously present was degenerated, and the phagocytosed by the tissue macrophages. Okay. Now the nerve repair. So neuronal repair may only occurs physiologically where nerves are in direct contact. Where a large defect of presence, the process of nerve degeneration is hampered, it is not formation. So let me see the things, three things: neuropraxia, exotemesis, and neurotemesis. So neurotemesis means complete gap of the axons. There is no connection between proximal and distal area due to a road traffic accident or on sharp cutting injury. So this can be regenerated like this. Okay. And in case of neuropraxia, only compression of nerve axon, but there is no disruption of nerve membrane, myelin sheath along with the axon. So there is a chances of repair automatically In that case, exotemesis is severe compressions and along with some degeneration. In that case, it's called the Buckner band, and this is called ectomesis. Now, the absence of vas deferens. What will be happen if someone has no vas deferens? So, absence of vas deferens can be occurs unilateral or bilateral. That is, cystic fibrosis CFTR gene mutation is seen at least 9 times. Okay, 40% cases that patient might have cystic fibrosis or CFTR gene presence. Some non-CF cases are due to unilateral anagenesis. That means once a teacher of me say that if you find any congenital anomalies, that might a lot of 2, 4 or more than 5 anomalies in that body, because the source is them, but from one source there are many organs is developed from our primitive sources. If there is a problem in primitive source, so in those organs will be affected later on and may cause through malignancy or lymphoma. Okay, so sperm devastating may allow for exceed conception. So if there is no vas deferens, so sperm pathway will be hampered, or there will be no sperm ongoing if that is bilateral. In that case, so we need to think about that. The cleft lip and cleft palate. So there are 3 kind of cleft lip and cleft palate and combined cleft and left palate. So the cleft lip and palate are the most common congenital deformity affecting the orificial structures. Okay, now cleft lip occurs in result of disruption of the muscle of the upper limb and nasolabial fold. So it's very clear that is upper limb and nasolabial fold, is it? And this muscle comprises of muscles of V's, nasolacrimal, bilateral, labiomental. Okay, now the cleft palate. So primary palate consists of all anatomical structures anterior to the incisive foramen. The secondary palate is more posteriorly and is subdivided into hard and soft palate. The cleft palate occurs as a result of fusion of the 2 palatine shafts. Both hard and soft palate may be required. So complete crease cases are associated with complete separation of nasal septum and vomer from the palatine process. So there is another defect of palate, and there is a congenitally not fusing together or have a foramen there. So surgically construction is the main treatment. The plan according to the entire malformation and axial. Simple defects are managed by the single procedures, and complex malformation are usually corrected by stages. Affected individuals have a higher incidence of hearing and speech problems. So later on it will be discussed like on. Now the choanal atresia. Choanal atresia is the incidence of 1 to 7,000 births. Posterior nasal airway occluded by the soft tissue or bone. Try to remember this very easily. Associated with other congenital malformations of coloboma. Babies with unilateral disease may also go unnoticed. In that case, choanal atresia will be developed. Now, achondroplasia is also common with dwarfism, causes a defect in the fibroblast and factor. In most cases, approximately 70% it will be sporadic in nature. The main risk factor is advancing the parental age at the time of conceptions, once it is typically inherited in the autosomal dominant fashions. Okay. So the parents might have a little age, that is 20 to 25 for the first baby, and also you need to complete your family planning within 30 years, that is 30 when the husband's age will be 30 and 25. You think you can skip the quality in that case. Now there are conditions like genetic and surgical, like Lufferman syndrome, so BRCA1 to Lynch syndrome. So this is very important for part 1, also the MRCS section 1 exam. That is also autosomal dominant mutations of p53 tumor suppression are the high incidence of malignancy, particularly sarcoma and leukemia, and diagnosed with individual in developed sarcoma under 45, first degree diagnosed with any cancer below 45 years and another family members, and develops malignancy under 45 years, sarcoma at any ages. Now carried out this chromosome 17 and chromosome 13 BRCA2 link developing breast cancer 60% cases, acid with developing ovarian cancer 50% and 24% BRCA2. So these two genes is very much responsible for pancreatic and breast malignancy. So there are two kinds of genes, that is chromosome 17, that is BRCA1, and chromosome 13, that is BRCA2. Now the Lynch syndrome is autosomal dominant and develops colonic cancer and endometrial cancer in the young. 80% affected individuals will get colonic and endometrial cancers, and high risk of individuals may be identified using Amsterdam criteria. Okay, now the Lynch syndrome develop colonic endometrial at a young age. 80% affected will be colonic and endometrial cancers. Yes, Lynch syndrome, colonic and endometrial cancers, and it may be happen in the young age. So high individuals may be identified with Amsterdam criteria. So Amsterdam criteria must be remembered. What it is? 3 or more family members with confirmed diagnosis of colorectal cancer. 3 or more patient. So one of the home is a first degree patient, like child bearing relative, other two successive generation and after generation, 1 or more colon cancers diagnosed under the 70 years, and family anatomosis polyposis coli has been executed. Now the Gardner syndrome. So Gardner, so autosomal dominant and familial colorectal polyposis, multiple colonic polyp may be present, and extracolonic disease including the skull, osteoma, and thyroid cancer, and epidermolysis tumors are seen in 15%. Mutation of APC gene loaded in chromosome 5, and then due to colonic polyps, most patients will undergo hemochromatomy to reduce the risk of colorectal cancers. Now consider a variant of familial adenomatous polyposis coli. Okay, so in case of FAP or familial adenomatous polyposis coli, there is chances of 100% of affecting with the 99% affected chances to become Gardner syndrome occurs. So there are some three that is, you must remember these things. Here 125 ovarian cancer, here 99 for pancreatic cancer, 15.3 for breast cancers, and there are some monoclonal antibodies. So antibodies like prostate specific antigen, prostatic carcinoma, hepatocellular protein, hepatocellular carcinoma and teratoma, and carcinomembranous antigen is a colorectal cancers. Okay, so this is the lymphoma is one of the malignancies of lymphatic system, that is Hodgkin's 1 and Hodgkin's 2. So mostly it is asymptomatic lymphoma and cough and peel, Epstein fever, hemolysis and dyspnea, and 10% weight loss and fever and weight loss. Okay. So what are the stages? Single lymph node, 2 or more lymph nodes, involvement lymph node and other both sides, and involvement of the extranodal sites. Okay. So Hodgkin's lymphoma can be diagnosed by Reed Steinberg giant cell, and our honorable Prime Minister already gone there. And 2 or more relation is the same side of diaphragm, movement of lymph regions on both sides and diaphragm in extranodal tissue. Okay, so there are some types of Hodgkin's lymphoma, that is nodular sclerosis, mixed cellularity, lymphocyte depleted, and lymphocyte rich classical Hodgkin lymphoma, and which is more common, that is. Okay, giant cell may be identified histologically. Okay, we need to identify it histologically. A fifth subtype, nodular lymphocyte predominant Hodgkin's lymphoma, characterized by the different cell type. Steinberg cells are rarely seen. So treatment, it may be multimodal. Both chemo and radiation are used, that made by incision complete lymph node in the submitted or the detailed histological evaluations. Pathologies, infection of Epstein-Barr virus like condition, and the stage 1 disease associated survival 85%, and this lymphocyte rich classical lymphoma has the best prognosis. Lymphocyte depleted Hodgkin's lymphoma, advancing age, male, sex, and stage 4, these are also associated with worsening of the prognosis. Okay, so that is, you can see there is a cartoon when that is clonal B cell that develops within the lymphatic system, who he cannot recognize. The malignant Reed stem cell typically has a bilobed nucleus that gives an owl eye appearance. Okay, and diagnosis and spread over the fashion adjacent nodes. If it is spreading, you are next. Okay, So that is all about our today's second part of Pathology 1. So I hope you like my channels and subscribe and see daily videos for MRCS as well as the belly lab. So I want to thank you to the Almighty that I have passed FCPS part 1 and MRCS part A in this session. So I think it will be nothing if you guys don't give me opportunity for performing surgeries along with institutional support. So I hope we will discuss with the rest of the topics tomorrow. Thank you very much for patience hearing.